disease. In fact, if you follow up these patients with left bundle branch block for several years, then they develop coronary artery disease or cardiomyopathy in a significantly higher proportion than do patients without pre-existing left bundle branch block. Looking at left and right bundle branch block in acute MI, we must understand the arterial supply. If you look at the right bundle branch is relatively superficial and slender and supplied by the left anterior descending artery, specifically in most patients by the first septal branch of the left anterior descending artery. So the right bundle branch block is not supplied by the right coronary artery. The right bundle branch block is supplied by the left anterior descending artery. Please remember that, and it has a single blood supply. That's the main trunk of the right bundle we are talking about. The left bundle, conventionally we talk about two fascicles. We know that the left bundle is more than two fascicles, but we'll stick to the two fascicular concept of the left bundle. And if you look at the left bundle, the anterior fascicle is supplied by the left anterior descending artery. If you look at the posterior fascicle, which is more resilient, it is supplied predominantly by the right coronary artery. This is very important to remember. And last but not the least, the bundle of His and the AV node is supplied again by the right coronary artery. So the right coronary artery supplies the AV node, the proximal bundle, and even the proximal left bundle. But the moment one goes beyond the very proximal left bundle into the fascicles, there is no single artery that supplies both fascicles. Therefore, remember that in anterior wall infarction, which is because of the LAD occlusion, you cannot get, logically speaking, left bundle branch block, because the left bundle is not supplied by the left anterior descending artery. However, you quite commonly get left anterior fascicular block in anterior wall myocardial infarction. And equally commonly you can get right bundle branch block, and actually you can get a combination of right bundle branch block and left anterior fascicular block in patients with anterior wall myocardial infarction. When you do get left bundle branch block with acute anterior wall myocardial infarction, an ECG pattern, it's usually a pre-existing left bundle branch block, and then the patient develops an anterior wall myocardial infarction. This is very important because the previous criteria for thrombolytic therapy, which said that anybody with left bundle branch block and chest pain give thrombolytic therapy, is now toned down, modified, and in some guidelines even removed. You have to have more evidence than just left bundle branch block to give thrombolytic therapy. On the other hand, I showed you that the right coronary artery supplies the bundle of His and also the proximal left bundle. So in a right coronary artery occlusion, that means in an inferior wall myocardial infarction patient, you can sometimes have a fresh onset of left bundle branch block. The situation in anterior wall infarction when you can get left bundle branch block, of course, is rate related. Patients who are bad, patients in failure, patients with a lot of sinus tachycardia, and get rate related bundle branch block, that is the time you can get a fresh left bundle branch block during an acute anterior wall myocardial infarction. The criteria were well outlined in the previous talk. I'll just reiterate them. In left bundle branch block, to diagnose acute myocardial infarction, you require a concordant ST elevation. That means a lead which has a positive QRS complex shows you ST elevation, or you have a grossly discordant ST segment. That means in a negative QRS like V1 or V2, you have gross ST elevation, or in V1 and V2 you actually have ST depression. So you have concordant ST elevation, concordant ST depression, or markedly discordant ST elevation. To diagnose an old myocardial infarction in left bundle branch block, any Q wave in the lateral leads is significant. Or sometimes the sinus rhythm may not show you Q waves, but the patient develops a PVC. Make use of those PVCs. If the PVC shows you a QR complex in any lead except AVR and AVL, then that also may help you to diagnose an old myocardial infarction. This is an example of a patient where there is not much of a problem. The patient has a left bundle branch block, but it has not really troubled us in the diagnosis of an acute myocardial infarction, because in lead V5 and V6, you see gross, very obvious concordant ST elevation. So here there's luckily not much of a problem. You have a diagnosis of left bundle branch block and an acute anterior wall myocardial infarction. Here also, there is another patient who has left bundle branch block, borderline left axis deviation, and concordant ST elevation. So concordant ST elevation, clearly the diagnosis is here, anterior wall, acute anterior wall myocardial infarction. Luckily, left bundle branch block doesn't interfere so much with the diagnosis of acute inferior wall myocardial infarction, because anyway you have, the problem comes in V1 and V2 in left bundle branch block because you don't know what to make of the ST elevation. But in inferior wall myocardial infarction, where you're dealing with lead 2 and lead 3, which have, if they have positive R waves and simultaneous concordant ST elevation, it's not so difficult to diagnose an acute myocardial infarction. So left bundle branch block with inferior wall myocardial infarction, acute, is easier to diagnose than anterior wall myocardial infarction. The examples that I'm showing you are very, very obvious and therefore not difficult to diagnose, but sometimes you have very little ST elevation, and that's where really you need additional evidence, like either the enzymes, you need the enzymes, or echocardiography showing gross wall motion abnormalities, where the ECG really is not very helpful with LBBB. The ones that I'm showing you are really the obvious ones. This is an example where you see a patient who's come in with chest pain in April of 1993. You see left bundle branch block. You also see left atrial enlargement. So this is probably a long-standing underlying cardiac problem, but he's developed fresh concordant ST elevation in V6. And there's also low voltage in the limb lead. So overall it tells you it's a sick heart. It's a sick heart. On top of that, the patient has developed a fresh anterior wall myocardial infarction. This patient was known to have ventricular dysfunction, and when you look at his ECG a month ago, clearly shows you a pre-existing left bundle branch block. So patients, again I'm making the point, patients who come with an anterior wall infarction with left bundle branch block, usually it is a pre-existing left bundle branch block. So to summarize, right bundle branch block, I would say, is more common in acute MI. Left anterior fascicular block is more common in acute MI, but left bundle branch block is less common as a fresh finding in acute MI. Inferior wall myocardial infarction, especially with bradycardia, what we call phase 4 blocks, you might find left bundle branch block. What about right bundle branch block in acute MI? The incidence is about 10%. 60% of them are isolated right bundle, but in 40% there's associated left anterior fascicular block. We know that patients with RBBB and acute MI fare worse. They have higher incidence of AV block, they have higher incidence of heart failure. And even 1-year mortality is very high if they have a new right bundle, because I said that this is, proximal LAD occlusion, large myocardial infarction. Of course, these are older statistics now with very aggressive intervention and quick restoration of flow. This may not be so bad, but 1-year mortality is definitely significantly higher if it doesn't resolve, if there is associated left axis deviation, and with anterior wall myocardial infarction. Generally, right bundle branch block should not interfere with the diagnosis of acute myocardial infarction. This is an example of QRBBB with ST elevations, an established anterior wall myocardial infarction with right bundle branch block in the acute stage. There's also sinus tachycardia telling you this patient is definitely not doing well, and as you can see, the left anterior descending artery was completely chopped off soon after the origin. So it's a large myocardial infarction. We've already said this before, that it predicts proximal occlusion because the first septal supplies the right bundle. When the QRS is very wide in right bundle branch block in acute MI, and when the ST segments don't resolve, these patients do badly. Also, they have a much higher incidence of ventricular fibrillation and cardiac arrest. So if you see RBBB in acute MI, be careful. Keep the defibrillator close by. Old myocardial infarction, again, is not much of a problem with right bundle branch block. This is an example of Q waves with right bundle branch block, old anterior wall myocardial infarction with right bundle branch block. And here you have Q waves in 3 and AVF with right bundle branch block. So old inferior wall myocardial infarction with right bundle branch block. Patients with right bundle branch block with old myocardial infarction, the incidence is about 7%. They have a lower ejection fraction, and they have higher, obviously, interventricular dyssynchrony, which generally many patients with RBBB, they would have interventricular dyssynchrony. Next we come to WPW syndrome. Here, more than acute MI in WPW syndrome, the bigger problem is the absence of acute MI, but a wrong diagnosis of acute MI or wrong diagnosis of old MI with WPW syndrome. Let's look at this example. This is a patient with Wolff-Parkinson-White syndrome. You can see the short PR and the delta wave. You see it well in lead V2. You see it very well in lead V2. But the limb leads give you these Q waves or a small r deep S. So you think there's a loss of the R waves. Is this an old inferior wall myocardial infarction? It's not rare to see such patients coming with some chest discomfort. They've just had an episode of tachycardia. They've perceived it as chest discomfort. They come into the hospital, tachycardia is settled. This ECG is taken. Some resident feels, oh, this is problematic, and they get thrombolytic therapy. They've undergone angiograms. This is during ablation. A procedure was being carried out during this tracing, and the WPW has disappeared, just to show that these so-called Q waves were pseudo Q waves because of WPW syndrome. Look at this dramatic example. This was a middle-aged man who has a recent cardiac arrest. His brother-in-law was an intensivist who lived in the same apartment complex. And he rushed, found him in cardiac arrest, resuscitated him. And after resuscitation, rushed him to the hospital where the ECG was taken and diagnosed as an infero-posterior myocardial infarction because it showed Q waves in 3, in AVF, small in 2, and R wave in V1. And he was thought to have ventricular fibrillation, which was resuscitated. He was admitted in the ICU and soon enough got tachycardia degenerating to ventricular fibrillation, and he was shocked. This kept on happening so many times that his chest was burnt. Actually, the superficial skin had actually peeled off, and he was given antiarrhythmic drugs, anti-anginal drugs, loaded with dual antiplatelets, given heparin, put on a ventilator, taken to the cath lab, underwent an angiogram, and not surprisingly, the angiogram was completely normal. So 1 week later, we took him up for an EP study and could easily induce what Sriram just talked about, narrow QRS, that is orthodromic AVRT, orthodromic AVRT. He had an accessory pathway on the left side, which was giving the false impression of a posterior wall myocardial infarction. RF ablation was done, and this so-called R wave in V1, the V2 is here, or the so-called Q wave in lead 3 disappeared, and there's a normal ECG. After that, EP study was repeated. There was no VT inducible. There was no AF inducible. So this is the problem with WPW syndrome, misdiagnosis of myocardial infarction in patients with WPW syndrome. This is another example of a patient with WPW syndrome. Another situation where wrongly they could be diagnosed as having acute ischemia is when the accessory pathway conduction disappears. So this is clearly a delta wave, positive QRS, short PR. The pre-excitation disappears, in this case by ablation. But imagine if they spontaneously had intermittent pre-excitation and the pre-excitation disappeared, and you find tall T waves. These are very tall T waves. By definition, abnormal T waves can be misdiagnosed as an acute myocardial infarction. This is also an example of what we call the memory sign. The memory sign. Whenever there is abnormal wide QRS, be it because of WPW or bundle branch block or pacing, when the wide QRS disappears, it leaves its footprints, it leaves its memory in the form of T wave changes which are transient, but that transient period could last sometimes for several hours. The leads where the QRS was negative will show T inversion. The leads where the QRS was robustly positive can show tall T waves. So remember the memory sign. Many people have gone for unnecessary diagnosis of ischemia for post WPW, post pacing, post tachycardia termination, T wave changes. Finally, we know that patients with permanent pacemakers, especially ventricular pacing, is quite difficult to diagnose acute myocardial infarction from the ECG. Most pacing is done from the right ventricular apex, so it gives a left bundle branch block with a left axis deviation. And the principles on the ECG of diagnosing myocardial infarction in patients with pacing is therefore exactly similar to the principles used for diagnosing MI in patients with bundle branch block, left bundle branch block. So the same Garbosa's criteria, which we talked about for left bundle branch block, could be used to help diagnose MI in patients with pacemakers. This is an example of a patient who had a pacemaker implanted in the past and who came with chest discomfort. So the question is this ischemia? So what we see in the ECG is a P wave followed by pacemaker spike followed by QRS. So every time there's a P wave preceding. So it's an AV sequential pacemaker. The QRS axis is leftward. So it's apical pacing. And then if you look at lead V1 and V2, then you have a negative QRS or a predominantly negative QRS with ST depression. So it's a concordant ST depression. So yes, you should strongly suspect ischemia and treat as ischemia pending further reports. This patient was treated with nitroglycerine, given beta blockers to slow down the rate. 1 hour later, the rate settled down, the patient was comfortable, and those ST depressions in V1 and V2 disappeared. So yes, in this patient it was possible to diagnose ischemia from the ECG, but sometimes it's quite difficult and you need other modalities. So in short, left bundle branch block and pacing do hamper the diagnosis of myocardial infarction. Right bundle branch block generally doesn't, and WPW in the absence of MI causes a pseudo-diagnosis of myocardial infarction quite often. Thank you.
Thank you, Yash, for an excellent exposition of ECG diagnosis of MI in LBBB, which can be very difficult. Now, due to shortage of time, because we are running late, there will be no questions. If there are any questions, you can contact the speakers directly. Thank you.
I request Dr. J. Prakash S. to felicitate our speaker, Dr. Yash Lokhandwala. I request Dr. Yash Lokhandwala to hand over the certificates to the chairpersons.
For the next session, I invite the chairpersons, Dr. Ram Prakash, Senior Electrophysiologist from Coimbatore, Dr. Mohammad Ghosh Sharif, Professor and HOD of Mysore Medical College and Research Institute, Dr. Devdas Rai, Professor in AJIMS, to kindly take your seats. I invite Dr. Mohammad Harun Rashid onto the dais to speak on utility of ECG in the evaluation of bradyarrhythmia in ICU. I request the chairpersons to introduce Dr. Mohammad Harun Rashid.
Good evening. So already since morning we have an extensive talk over ECG and its importance. And we already discussed about the bradyarrhythmias and various causes for it, starting from sinus bradycardia to various types of blocks as well as the complete heart block. Today, Dr. Harun Rashid is going to discuss how ECG is going to help in the evaluation of bradyarrhythmias in ICU. He is a consultant electrophysiologist, Apollo Hospital, Bangalore, and he has special interest especially in sudden cardiac death, risk stratification, syncope evaluation, arrhythmia management, MI angioplasties, heart failure, atrial fibrillation, etc. He has awarded European Young Investigator Award in Cardiac Electrophysiology Spain in 2011 and European Young Investigator Award in Heart Failure Belgium 2012, and he has presented so many papers in national and international conferences. Over to Dr. Muhammad Harun Rashid.
Good afternoon. Thank you very much, chairpersons, for the introduction. After a fast-paced ECG session, we'll go on to the bradycardias now. And again, my topics have been mostly covered by the previous speakers, but still, in ICU, I would like my talk to be with SA conduction abnormalities, bradytachy syndromes, and AV disturbances. I will just briefly talk about the mechanism, the causes, and the ECG diagnosis which we are gathered here for. Before going on, I would like to again reinforce on the definition which is essential in understanding what I'll be speaking in my further slides. So what is the SA block? It is a conduction disorder in which impulses generated in the sinus nodes are intermittently conducted or not conducted to the atrial myocardium, or otherwise a transmission failure. What is a sinus arrest? It is a disorder of the automaticity in which no impulses are generated within the sinus node, or otherwise a generator failure. And sixth sinus syndrome, as our previous speaker has elaborately spoken about, is a dysfunction of the sixth sinus node or SA conduction in which no adequate escape mechanism is present, and the patient becomes symptomatic because of the bradycardia and cerebral hyperperfusion. Coming on to the SA conduction abnormalities, it can be manifested as the first degree, the second degree, the complete SA block. The second degree SA block may be of type 1, similar to that of AV node abnormalities, type 2 or type 2 Mobitz 2, or 2 to 1 SA block, which looks like sinus bradycardia. SA Wenke-Back and Mobitz type 2 SA block can be recognized on the ECG and differentiated from each other because of the pattern of the PP interval before the drop.